Hello, today our topic of discussion is pelvic inflammatory disease PID. What is pelvic inflammatory disease? It is a spectrum of infection and inflammation of upper genital tract organs, typically involving uterus, fallopian tube, ovaries, pelvic peritoneum, and surrounding structures. Next, move on to epidemiology. It is mainly due to a sexually transmitted disease. It varies from 1 to 2% per year among sexually active female. For 85%, it mainly spontaneous infection in sexually females and 50% for procedure, that is endometrial biopsy, incision of IUD, uterine curettage. Next, move on to risk factors. First one, menstruating teenage. They have low hormonal and cell mediated defense. Second one is multiple sexual partner. Third one is IUD users. Fourth one is absence of contraceptive pill use because it produces thick mucus plug and prevent the absence of sperm and bacterial penetration. Fifth one is area with a high prevalence of STDs. Next, move on to protective factors. It mainly involve two criteria. First one, contraceptive practice. Second one, others. In contraceptive practice, it mainly involve first one, barrier method by use of any condoms. Second one, oral steroid contraceptive because it reduces the thick mucus plug and decreases the duration of menstruation. And third one is monogamy. And others include first one, pregnancy, second one, menopause, and third one, vaccines. For example, hepatitis B. Next, move on to pathology. The pathological process is initiated primarily in endosalpinx, cross destruction of epithelial cell or cilia or microvilli. It become edematous and hypermic, that means severe infection. This exfoliated cell with the exudate pour into lumen of tube and it agglutinated the mucosal folds. Due to edematous fimbria and inflammatory adhesion, there is a closure of abdominal ostium occurs and also closure of uterine end by the congestion. If the closure of a both ostia will occurs, the pent of a exudate inside the tube. This purulent exudate then changes the microenvironment. It favors the growth of microorganism and deeper the penetration and more tissue destruction. Next, move on to stages. It involves the 5 stages. Stage 1 is acute salpingitis without peritonitis, there is no adhesion. Second stage is acute salpingitis with peritonitis, that is a purulent discharge. Third stage is stage 3, that is acute salpingitis with superimposed tubal occlusion or tubo-ovarian complex. Fourth stage is ruptured tubo-ovarian abscess. Fifth stage is tubercular salpingitis. Next, move on to clinical manifestation. The main clinical manifestation involve nausea, vomiting, dyspareunia, pain and discomfort related to hypochondrium due to concomitant perihepatitis. It is termed as Fitz-Hugh-Curtis syndrome. And last one is abdominal discharge. Complication or long-term problem involve recurrent PID, ruptured abscess, chronic pain, ectopic pregnancy, infertility, perihepatic adhesion, that is Fitz-Hugh-Curtis syndrome. Next, move on to investigation. The investigative methods are first one, ultrasound, second one, culdocentesis, and that is aspiration of a peritoneal fluid and its WBC if exceeds 30,000 cell per ml and it is termed as acute PID. And third one is smear and culture from urethral secretion. Fourth one is laparoscopy. Next, move on to treatment. The principle of therapy involve first one, to control the infection energetically, second one, to prevent the infertility and late sequelae, third one, to prevent the reinfection. Treatment for outpatient therapy. First one, adequate rest, second one, analgesic, third one, antibiotics. The major antibiotics are doxycycline 100 mg BD, erythromycin 500 mg QID, metronidazole 400 mg BD given for 4 to 15 days. Treatment for inpatient therapy. It includes first one, antibiotic therapy, in that cefoxitin 2 gram IV 4 times a day or 2 to 4 days. Second one, gentamicin 2 mg per kilogram body weight, loading dose followed by 1.5 milligram per kilogram. IV as maintenance dose every 8 hours and metronidazole 500 mg given every 8 hours. Second one is bed rest. Third one is oral feeding restricted. Fourth one is IV fluid to correct the dehydration and acidosis. And fifth one is IV antibiotic therapy at least 48 hours may be extended to 4 days. Parenteral treatment involved regimen A, that is cefixime 2 gram IV every 6 hours plus doxycycline 100 mg orally or every in 12 hours for 40 days. Next, move on to prevention. First one, health education, patient to avoid the reinfection and potential hazards. Second one should be warned against multiple sexual partner. Third one, to use condoms. Fourth one, to sexual partners are to be traced and properly. And last one is follow-up. This is regarding the small description of pelvic inflammatory disease. I hope you all are clear with this topic. Thank you.
Wow, that's impressive! You have completed a magic today. For more videos, subscribe. Join our Facebook group and Instagram page for group discussion and live magazine videos for exam preparation in an hour. We start a class-like community for students to learn from a friend in a simple way and support them in their own languages. If you are willing to be that one friend who saves us at the exam night preparation, then please join us by visiting classfly.in.